So this first case, this patient presented. It's a young patient. The patient is 12 years old, and the patient had a traumatic injury to their upper central incisor. Obviously, okay. When you have a situation where you have a break in the enamel, the dentin, and the pulp, that's classified as an Ellis Class 3 fracture. All right, and the patient was experiencing some pain to cold and also some pain to percussion. All right. So in terms of the diagnosis of the case, I want you to just think about this. We are going to be going over this very shortly, but the diagnosis for this is symptomatic irreversible pulpitis with a symptomatic apical periodontitis. All right, and you can see very clearly when you look at the radiograph that the tooth is an immature tooth. The apex is relatively wide, but it's not crazy wide. Generally speaking, as long as you have an apex that's around a size that's smaller than a size 100, that's going to tell you that you can proceed with traditional endodontics with, files, gutta percha, and sealer, as opposed to having to place an apical barrier of MTA or some sort of other bioceramic material as a plug in the apical area. This case actually has an apical size more in line of size 50 to 60, but we'll go into that. All right. So again, I want you to follow through step by step. We've already anesthetized this patient, and they're ready to go. So without further ado, let's get started. All right. So obviously, step one is to place the bite block after your anesthesia delivery. And you've letting it set for at least 5 minutes, and then you're going to proceed with your rubber dam isolation. So we used this clamp number 9T. Clamp number 9 works fine as well. The 9T just has some serrations that maybe let it hold a little better, but a size 9 clamp works just as well. So rubber dam isolation is your first step, and then we're going to proceed with our access preparation. So when you're performing your access preparation on anterior teeth, you're generally going to start with a size 2 surgical length round burr. All right, that's going to give you the ability to start nice and small and drop right into that canal, which is what we like to feel. So you want to be able to start with your initial penetration into the dentin, and we want to feel that little drop right into the access preparation, okay, or right into the pulp chamber, I mean. And you're going to go slowly, slowly, slowly. And a case like this where the apex and the root canal system is unbelievably large, it's going to be much easier, obviously. So you're going to feel that really obvious drop right into the pulp chamber. So take your time, kind of feeling the mesial and distal extent of that pulp chamber, so that you make sure that you unroof the entire pulp chamber. That's super, super important, so that you remove all the pulp tissue in the pulp horns. All right. What can happen if you leave pulp tissue behind on an anterior tooth? You can end up the patient will suffer from discoloration in the future, and you don't want that. So reach for your DG16 Endo Explorer. Kind of poke right into the pulp just to confirm that you're in the tissue, and there you go. And then you're going to move forward with your orifice opener. So I recommend the ProTaper Gold SX orifice opener, and it's a short file. It's just meant to engage in the coronal to mid portion of the root, and you want to just brush it in all directions, mesial, distal, buccal, lingual, just so that you're only opening the orifice of that canal. And then you go ahead and you're going to want to rinse with copious sodium hypochlorite. I recommend a 50-50 dilution. All right, so it's an approximate 2.5% concentration, and you're going to use a ton of this during the procedure. Typically, somewhere between 10 and 20 milliliters is going to do the trick. And as you're kind of refining your access preparation, I'd encourage you to take a look at what you got. And if you need to smooth out the walls, you'll want to go ahead and do that, before you get too deep into the instrumentation process. So, I'm using a round burr here just to smooth out the walls so that there's a lot of confluence between the canal space and the access preparation. You want that nice funnel shape. Okay, and we did this, obviously over and over again in dental school on plastic teeth, before we even, went live on a patient. So you know what I'm talking about when I say that triangular shape. But, you want to take your time. You want to make sure you unroof all the pulp horns and the patient has no remaining pulp tissue left inside their tooth. So, take your time. And it's easy to leave ledges, especially on the facial. You don't want to go too far and, potentially weaken the facial tooth structure, but you want to, not have any rough edges. You want it to be nice and smooth to receive your instruments and to thoroughly disinfect the internal aspect of the tooth. So, like I said, lots and lots of sodium hypochlorite here. And now we're going to proceed to continued refinement of the access preparation using a Gates-Glidden burr. So I don't typically recommend utilizing Gates-Glidden burrs because they can weaken the middle, third of the root. All right, so I'm just running it really, really slow, barely pressing on that rheostat, again, just to smooth out the walls. You'll find oftentimes that access preparation on anterior tooth actually could take more time than on molar teeth, just because there's a lot more of unroofing that needs to happen with those pulp horns. So now we're proceeding with our working length determination and our glide path. All right, so a case like this, the canal is just so large that I started with a size 35 K file, and you're going to slowly introduce that into the canal, making your way to the apex, and then we want to use our apex locator clip. All right, that's going to give us our electronic reading as to what the estimated working length is going to be. And you want to introduce the file with the apex locator. You don't want a bone dry canal space, but you don't want a canal space that's overflowing with irrigating fluids. All right, so somewhere in the middle. But if you have multi-canals, you don't want the fluids to be in communication with other canal orify, because that can give you a jumpy reading. And the canal was so large and that I actually went ahead and increased the size of the K file in determining the working length to a size 50. So this is a size 50 K file, and again, I'm just checking that working length with the apex locator to make sure that I have a rock solid reading. You want the apex locator to not be jumping at all. You want it to be nice and steady, and again, with a wide canal, every time you move the stopper or you put the apex locator clip on there, it might move a little bit because we have a canal that's so big, and so you want to take your time with that. So you'll check over and over and over again before you take your working length radiograph. All right, but this is a super important step, and you want to make sure that your instrumentation is at the perfect spot so that you don't enlarge what is already a very large apex. Right? We want to maintain that size. We don't want to make it any bigger than it already is. And I'm determining here with my apex locator that the working length is 19.5 millimeters. There's our radiograph, and you can see that I'm slightly short there. So I'm going to go ahead and increase 1 millimeter, and I'm going to do that, right then and there. I can already tell that now at the increased working length, at 20.5 millimeters, I'm actually getting right to the apex, and it's much more snug than it was before. So, in terms of apex locators, generally speaking, if it's a tight canal, you're going to get a more steady reading, but you want to trust them, but verify, right? Trust, but verify. So you want to trust them, but you want to take your radiographs to make sure that they're giving you the right reading. So now we're starting with our size 40 Vortex Blue 04 taper file. That's going to be the introduction to the instrumentation phase of our treatment. And every time we go in with a new file, once we've reached working length with that file, you want to give another copious rinse with sodium hypochlorite. And now we're just moving up the ladder. This is the the easy part, if you will. So now we're using our size 45 Vortex Blue 04 taper rotary. Again, irrigating with our sodium hypochlorite. And we're just continuing to go up the ladder until you feel that the file is nice and snug in the canal, especially at that apical region. And you can feel that, okay? But you know, a case like this, you don't have to worry so much about file separation because it's such a big canal. But now we're going on to our size 50 Vortex Blue 04 taper rotary file. So we worked our way from 40 to 45 to now 50. And I'm starting to feel a little resistance there, and I'm feeling good about that. So again, sodium hypochlorite rinse, and then we're going to proceed to gauging the apex, okay? So, you know, with tight canals on a multi-rooted tooth, this isn't as critical, but with a large canal, we want to be very, very precise as to what that apical size is, so we don't make a mess with our obturation materials and overextend our gutta percha. So I actually introduced a size 60 hand file here to length, just to make sure that it's really snug in that apical area, so I feel confident that I'm not gonna push any of the obturation materials out of the tooth. And that felt really, really, really good, that size 60 K file. So I know my apex is a size 60. And now we're just going into the disinfection stage. All right, so a lot of sodium hypochlorite, aspirated out, and then proceed to our 17% EDTA rinse. You only need about 3 milliliters of this. You want to place it, let it soak for 30 or so minutes, or 30 or so seconds, and then you're going to aspirate the EDTA out, and then go back to your sodium hypochlorite. So that's the routine for your disinfection. You're going to do your sodium hypochlorite rinse, aspirate out, 17% EDTA for 60 seconds, aspirate out, and then back to a final flush with your sodium hypochlorite, which is what I'm doing there, and then going ahead and aspirating that out. All right, I'll go over why we do that later on in the course, but this is the routine that I would highly recommend to get your cases nice and clean after you've done all your instrumentation. So now we're gonna move to our obturation phase of the procedure, okay? So I'm using a size 40 paper point here. Generally speaking, for most cases, an F2 paper point is great. You can use that if you'd like. You might just have to go through a few of them as opposed to just one or two, or you can even turn that F2 paper point, which is the red one, around and use the blunt end. That works as well. And you can see we have a nice dry canal. You can see the apex there. Everything looks nice and clean, and we feel good about filling this case. So now we're going to go ahead and introduce our sealer into the root canal space. So you can inject directly into the canal. You just want to make sure that the tip is not binding anywhere, so that it's a passive fit and it's just filling up the canal space without extruding. And now we're going to seat our master cone, which is our size 60 gutta percha point. And what you're going to do is you're going to dunk the gutta percha point into the sealer tip after you've removed it from the main hub of sealer, and then you're going to seat it to length. And I will show you that in future case demonstrations as well. But this case, is a really quick case, and it only takes 15 or 20 minutes to do a case like this. All right, so it's seated to length. That feels nice and snug in the apical area. And because this canal is so large, we're going to introduce some accessory cones. And in this case, we used size 40 accessory cones. But you just want to get a cone that's big enough that a couple of them is going to take up the remainder of the space in the middle of the canal. So as many as it takes in order to do that. I wouldn't go to tiny little gutta percha cones and using 20 of them. And here's our cone fit radiograph. That looks good. We feel happy with that. and you can see that we used 2 accessory cones there and the main size 60 gutta-percha cone that's seated to length. And we're going to sear off those cones with our System B heating element with a fine medium 08 tip attached to the System B, and we're just searing off right at the orifice. Okay, I'm recommending a really simple obturation technique that's called hydraulic condensation. I will go over that further in the didactics, but you'll see that over and over and again in the live case demonstrations. So with a large canal, this last step of cleaning up in the axis preparation and at the canal orifice is going to take a little longer because there's going to be a lot more excess gutta-percha because it was such a large canal space. So you'll see me just continuously making sure that the gutta-percha ends at the root canal orifice, not too far below, and definitely not too much excess, so that the restorative dentist, in this case you, has enough space to restore the case with a nice composite resin that's going to give the patient a really good aesthetic outcome. And we're using our Buchanan pluggers. In this case, we're using the blue plugger, which is a little bit larger than the red plugger because the canal space is so large. And gently compacting in that area. You don't have to press, crazy hard. Just a gentle, with firm pressure, a gentle amount of pressure right at that canal orifice, just to, flatten that interface between the gutta-percha and the canal orifice. You want to have a really clean internal aspect here. And in order to clean out all that extra sealer, I encourage you to simply use water with your air water syringe. And so you want to go ahead and spray that with lots and lots of water. The water's not going to harm the set of this sealer. This is a hydrophilic material, and it's going to do just fine with some water. The same can't be said for other sealers used in other obturation techniques. A little water here is not going to make or break the case by any stretch. So you can start to see that it's looking nice and clean on the internal aspect, and we're just going to make our finishing touches just to flatten out that gutta-percha at the orifice. And so now you'll notice that I will be proceeding here shortly with the temporization of this case. I would encourage you as the restorative dentist to feel free to go ahead and restore this case right now. Why put the patient through another visit? Number one. Number two, you already got a nice clean area with a rubber dam on, so don't be shy about restoring a case like this. You're actually potentially doing the patient a big service because they're not going to be risking contamination of the temporary material over time, and you got a nice dry working field. So it's a great time to restore the case right here and now, and save yourself the 20-30 minutes of chair time in the future. And so you'll see now, and I'm just cleaning out with a cotton pellet, and I used another paper point to clean out some excess sealer just a second ago. All right, but if you want to go ahead and put your acid etch in there and your bonding agent and your core buildup, go for it. Why not? You may want to simply place enough composite to seal it a little bit and then remove the rubber dam so that you can build up the remainder of the tooth, and then work on your fancy embrasures and your beautiful translucent resin materials just to get that anatomy perfect. But in this case, we're going ahead and just using sterile sponge and cavit in preparation for the patient to go back to the restorative dentist, right? And then we just use a moist pellet just to burnish that cavit into the area, just to get a good seal. And there you have it. That's the end of the case. So you can see very clearly that a case like this shouldn't take a whole lot of time. It really should only take once you get good at this stuff, 15, 20, 25 minutes at the most, and then you can proceed right to your core buildup, and you can have a root canal and a core buildup done in 30 to 40 minutes ideally, right? So don't forget to take out that bite block and then we're going to go ahead and take our post-op radiograph. And you can see that's a good outcome there. We want to try to achieve that on all our anterior cases. So we have a nice filled internal aspect that's adapted to all the walls internally, with a great root filling to the approximate or to the appropriate length, and it's just a nice uniform root filling. That's it. I hope you really appreciated and enjoyed watching that case, and there was minimal editing that was done, and that's going to be the case for all the case demonstrations. I did edit it just enough to make it feel engaging, so there's not a lot of, waiting for the mirror to come back into the picture kind of thing. But I didn't want to over-edit it and make it seem like, these kinds of procedures are done in like 3 or 4 minutes, right? So there's a fine line. So there was just minimal editing that was done in order to give you a realistic expectation as to how long these kinds of cases should take you in your practice.